Hey everyone, it's Carolyn and welcome back to my channel, or welcome if you're new. Really quick, I just want to say to my subscribers, I know this video is very different from my usual content, although I am very upfront about the fact that I am an ICU nurse. It is just not a part of my usual content on my channel. So I know this video might not interest you, but if you're watching anyways, thank you so much. My regular content is going to resume on Friday. So the reason why I am making this video is because last week I watched a very disturbing video posted by a woman who calls herself Sara NP, which stands for nurse practitioner, and she posted an absolutely horrifying video recounting the tales of a frontline worker in a New York City hospital. Basically, she's saying that nurses and doctors in New York City are letting their patients rot and die, and even went as far to say that they are being murdered. Her claims are absolutely horrifying, and I have to post this video because I cannot in good conscience let another day go by without saying something. All of her claims do not seem like they are backed by evidence. They are not backed by science. It shows a clear misunderstanding of the disease process, and I am here to sort of dive into everything that she is saying, give my take on it, and everything, of course, is going to be backed up by evidence and science. So right off the bat, I want to say if you haven't watched her video, you should head on over and watch that first. This is going to make a lot more sense. I am going to be providing a lot of direct quotes from the video, but you might just want to take the 10 minutes and watch it so you have a better understanding. I'll leave it linked down in the description box if you are not familiar with it. But right off the bat, there are a lot of things that she says that have me very concerned. The first being that she is recounting secondhand information. She is telling the tales that were told to her by a friend who was redeployed from somewhere else in the country to New York City. So she is providing secondhand information. We've all played the game of telephone before. We know how secondhand information is just not as reliable as firsthand testimony. So right off the bat, I have my doubts about what is being said because, again, she has not witnessed anything that she is recounting. The second thing that concerns me is she gives no information whatsoever about who is giving the information. She just said it's a friend that is too scared to come forward, but she doesn't say whether this friend has any background in critical care, if she's an ICU nurse, a nurse practitioner, a doctor, a respiratory therapist. We know absolutely nothing about this person. If they do not have a background in critical care and they are redeployed to an ICU in New York City, they are going to be shocked. I have been an ICU nurse for years, and what is going on is shocking. So if you are not familiar with working in critical care, you are going to have a completely different take on it than someone who is familiar with ventilators and critical care nursing protocols. It's just going to be a completely different perspective. So again, that was very concerning to me. And what is the most concerning to me is that her video is giving the impression that people should not be trusting the healthcare system, that they should not be searching out help from the healthcare system in New York City, that they should be refusing to be placed on ventilators. And this is very scary and dangerous advice. 2.5% to 5% of patients with COVID-19 require critical care, and that mostly means that they are going to be requiring a ventilator in order to survive. So if 2.5% to 5% of the hundreds of thousands of people that watched her video are too scared to go to the hospital and get the help that they desperately need, they are going to end up dying at home. And that is absolutely horrifying to me and is 100% the reason why I felt the need to make this video. So I'm going to be diving deep into what she said, reading direct quotes from her video and sort of refuting them, giving my take on them, telling you exactly what is happening in these hospitals because, again, I am a frontline worker. I'm an ICU nurse. I've been taking care of COVID-19 patients exclusively since March. I am a New Yorker. I am proud of my profession, my colleagues, my coworkers, the work that we are doing in this pandemic. It is truly heroic, and the fact that she is slandering us, I think, is disgusting. So I'm going to be sort of glancing over at my computer throughout the video just so that I don't misspeak when I am quoting Sara from her video. So let's get right on into it. So quote number 1, I am not on the front lines. So this speaks loud and clear. She is not on the front lines. She has not witnessed anything that she is testifying to. Again, we already talked about this. It's secondhand information. So right away, I have my doubts about what she is saying. She says it right there. I am not on the front lines. She does not see every day what is really happening, but yet she is testifying to what is really happening. Next quote, patients are left to rot and die. No one cares. This couldn't be farther from the truth. To say that no one cares, it's just a lie that I can't even imagine anyone actually thinking. Healthcare workers are risking their lives to take care of these patients. We're risking our families' lives, and there is no other reason why we would be doing that unless we cared. New York City has been hit harder than anyone. There's a national shortage of PPE. People were told on the front lines to wear a bandana or a scarf to take care of their patients. And the only way that you wear a bandana and go take care of a patient with coronavirus is because you have heart and you care. We care about our patients. No one is being left to rot. I have come home on more than one occasion and just collapsed and cried because of the sad events that I have witnessed that day. And I'm not crying for any other reason than because I care. And the day before I have to go to work, I start getting tightness in my chest because I know it's going to be another hard day and I'm going to witness a lot of things that are truly upsetting. And the only reason why that is happening is because I care about my patients. I don't want to see people suffering and I just want them to get better. And that is not the case for every patient. So we care enough to go to work, to reuse our PPE week after week, and we care enough to risk our own lives and our families' lives to take care of these patients. So to say that nobody cares is a lie. Next quote, it's the blind leading the blind. I don't know what she expects. This is a brand new disease. No one had even heard of it less than 6 months ago. So I don't know who she expects to be leading the blind. As far as I know, there are no experts in COVID-19. There are no tried and true treatments and protocols. We are learning new things about this disease every single day. There are no long-term studies. So of course it's the blind leading the blind. We are all learning what to do. Treatment protocols are changing constantly. So yeah, maybe you want to say it's the blind leading the blind, but we have no other choice because it's a brand new disease. No one is an expert on it, and we are all learning how to treat these patients. Okay. The next quote is, doctors are reporting around the country that they were using a combination of medications and people were not dying. People were getting better. These medications are not being used in hospitals in New York City. So I would like to know what these medications are, because the last that I heard, there was no cure for COVID-19. There are certainly treatments, but these treatment protocols have been changing as the new data has been coming in. So she doesn't say after this quote what these miracle medications are, but I would certainly like to know. And I did forget to say earlier that another thing that really alarms me about her video is that she says New York City as a general blanket term for what is happening. But again, we know that her information is coming from a single friend who was redeployed to work in a single hospital in New York City. And New York City hospitals are gigantic. They all have multiple ICUs. So we are really talking about testimony coming from a single person in a single hospital in a single ICU. So what may or may not have been seen in that unit might not even be what is happening throughout the entire organization. So to blanketly say that things are not happening in New York City is extremely irresponsible, because she doesn't know what's happening in every hospital in New York City. She doesn't have eyes and ears in every hospital in New York City. That's just impossible. New York City is gigantic and there are tons of hospitals and ICUs there. She can't possibly know what is happening in New York City as a whole. So I just wanted to also mention that. I forgot to mention that earlier. Next quote, if they require more than 6 liters nasal cannula, they get intubated, they go on the vent, or they get trached if there is not enough vents. So this is just one of many things that she says that has me extremely worried, because it shows a clear misunderstanding of what exactly happens in critical care. A trach is not an alternative for a ventilator. A tracheostomy is a hole in the neck. It is creating a secure airway. An airway is very different from a ventilator. So when someone gets intubated or they are having extremely difficult time breathing, we need to make sure we secure an airway, because their trachea can be inflamed with swelling or mucus, and then we won't be able to ventilate them. So we either use an endotracheal tube or we use a tracheostomy, but that in no way, shape, or form ventilates a patient. So they are not, it's comparing apples and oranges. You can't even compare them. They are two completely separate things. So this just goes to show she really does not have a background in critical care. And if her friend is telling her this, that patients are getting trached because there are not enough ventilators, then that goes to show that she has absolutely no knowledge of critical care as well. That's kindergarten level stuff that anyone with any small background in critical care would know makes absolutely no sense. So the next quote is, they don't get high flow, no non-rebreather, no non-invasive ventilation, no CPAP, no BiPAP. They are on a closed system for fear they will spread the virus. So she talks a lot about how hospitals are intubating patients when they do not need to be intubated, because they would prefer to have them on a closed system so there is less risk of transmitting the virus to the staff. So this information is either outdated or it's completely false. Early guidelines that we received from China did encourage us to intubate early, because the patients decompensate so quickly and you really need to intubate early in order to save lives. Over time, we have come to realize that this is not always the case. We are using non-invasive ventilation, CPAP or BiPAP when it is appropriate, and we are most definitely utilizing high-flow nasal cannula. We have many patients who are on high-flow nasal cannula, 100% oxygen, 40 liters per minute, and they also have a non-rebreather over that. So we are really letting these patients go as long as we can, and only intubating if they absolutely need to be intubated. So sometimes we do not have that luxury. Patients are waiting to come in until the very last minute, and they have absolutely no respiratory reserve left, and they need to be intubated right away, either right when they come in the emergency room or right when they get transferred to the intensive care unit, because we did wait as long as we could. So this might have been true weeks or months ago, but this is not true now. We are absolutely utilizing non-invasive ventilation methods. Okay, so the next quote, the patients don't know any better. They don't have family with them. There is no one there to advocate for them. They are scared and they give consent, meaning give consent for intubation. So she talks a lot about how visitors and family members are not allowed to be with the patients. And she says it as if we are doing it for any other reason than it is absolutely necessary. Like I mentioned, there is a critical shortage of PPE. There are not enough masks, not enough gowns, not enough gloves, not enough face shields for frontline workers who have to take care of these patients so that they don't die. If there's not enough PPE for the frontline workers, how are we supposed to provide PPE to allow family members to come to the bedside and stay with their loved ones? It's just not possible. And we can't allow family members in without PPE, because inevitably they're going to contract the virus and continue it to spread, and then the cycle is going to go on and on and on. So that is the reason why family members and visitors are not allowed into the hospital, because we do not have PPE to protect them. There is no other reason why. We are not the CIA. We are not trying to keep secrets. Nobody is left alone in the hospital. If you are awake and alert, You can have your cell phone at the bedside. You can call your family anytime you want. You can have your family speak to your doctor or your nurse. You can allow them to have permission to get medical information about you. There are not all these secrets going on that nobody on the outside knows what's happening on the inside. People have cell phones and they can communicate with the outside world and let them know what is going on. And for patients who are intubated and aren't able to call their loved ones, then we have iPads and we are FaceTiming the families into the patient's rooms in the ICU so that they can see their family members. Families are getting updates from the doctors, from the nurses, from social workers. It's not some secret society that is going on inside these hospitals. Family members are not left in the dark, not knowing what is going on with their loved ones. That's how it always has been. If patients cannot call their families, then the doctors and the nurses and the social workers update the families for them. We're not secretly trying to consent people to get intubated and put on a ventilator, because that isn't even a thing. If someone is in extreme respiratory distress, they are in no shape to sign a consent, which, by the way, you don't need a consent to save someone's life. If it is an emergency, you can go ahead and save that person's life. This again just goes to show how little she knows about what is actually the protocols and procedures of hospitals. You don't have to have someone sign a consent in order to be intubated and save their life. It's just not a thing. The next quote is, the ventilators have high PEEP, high pressure, which then causes barotrauma. It causes trauma to the lungs. So most patients who have COVID-19 and are intubated in an ICU are in ARDS. Their lungs and their airways are so stiff that their peak pressures are so high that we have to use high pressures on the ventilator in order to ventilate them. They will not oxygenate and get volumes from the ventilator without them. We are using the ARDSnet protocol, which is the standard of care for ventilating patients with ARDS. So again, this is very basic ventilator management knowledge. It again just goes to show she has absolutely no critical care background, because if she did, then this would be common knowledge and not a point that she would even need to make. So the next quote is, the protocol is propofol or some kind of sedation because they are on the ventilator, and IV antibiotics. There is no hydrochloroquine. They are not using that combination with Zithromax. They are not using zinc, vitamin C, high doses, vitamins A and C. So this actually has some truth to it. I have given hydrochloroquine and Zithromax to many patients, especially when we were first starting out. And believe me, this is not the end all miracle drug that we were hoping that it would be. I have seen plenty of patients die and they received this combination of hydrochloroquine and Zithromax, and the more data that we are getting in, the more we see that there is no association with improved outcomes when using that combination of medications, and in some cases we saw worse outcomes with it. As we all know, there is no medication that does not have side effects. Hydrochloroquine has a side effect that prolongs your QT interval, which can cause fatal arrhythmias, especially in cardiac patients. So we are not going to be using a medication that has a potentially lethal side effect if it is not associated with improved outcomes from the data that we are seeing. So her information is completely outdated, that everyone should be getting hydrochloroquine and Zithromax. That's just not the case anymore. The data is changing and protocols are changing rapidly. So you really have to stay up to date with the latest evidence-based information. So the next quote is, a code was called and no one came. So anyone who works in a hospital knows that when someone calls a code blue, there are a team of people that are called to respond. So this is doctors, nurses, respiratory therapists, anesthesiologists, surgeons, supervisors, security officers, chaplains. So if she is trying to say that out of all of those people, nobody is coming when someone calls a code blue, there is just no way that I would ever believe that. There is just no way that could be true. Someone out of that huge group of people is going to come. Now, when someone calls a code, it might look a little bit different. There are definitely going to be less people going in the room. We're not going to jam 25 people in the room all trying to get in there and help like we did before. There are going to be 2 or 3 people to do compressions, a nurse to administer medications. The physician might be in the room or just outside the room leading the code. So yes, it's going to look different, but believe me, we are resuscitating people. Now, if someone, it looks like that they are going to imminently code, they are maxed out on pressors, they are in maximum ventilator settings, and their oxygen levels are still dangerously low, we know that they are not going to survive a code. Believe me, we are on the phone with that person's family to let them know that they aren't going to make it. And we are talking about making them a DNR or a do not resuscitate. But if someone is a full code and they cardiac arrest, believe me, they are getting resuscitated. So the next quote is, they stay in the same PPE the whole shift, even if it is a rule out COVID. So this is complicated. I know it's going to be different from institution to institution, but rule out COVIDs are not treated the same as COVIDs. What she was saying in the video is that staff are using. So the answer to this is going to vary from institution to institution. Now, what she is saying in the video is that staff are using the same PPE in a patient's room that is positive for COVID, and then they are going into a room of a patient who is a rule out COVID. So they are potentially bringing the infection from the known infected patient into a patient who we don't know if they have it or not. So if they don't have it, they are just going to go ahead and get infected because of the staff using that same PPE. And again, in my institution, this is just not the case. A rule out COVID is treated differently than a COVID patient. And so how we are doing that is when we are organizing our care, we are going from room to room using the same PPE, but changing our gloves and washing our hands in between patients. But if we have someone who is a rule out COVID, we're going to be going in that room first with our clean PPE. We are going to be taking care of that patient, giving them their medications, repositioning them, cleaning them, doing whatever we need to do. And then when we leave that room, we're removing our gloves, washing our hands, donning new gloves, and going into the room of the patient with known COVID. So we are not bringing COVID from a infected patient into a patient's room that potentially does not have COVID. And that is just how it is being done at my institution. I can't speak to what is being done at others, but again, neither can she. The next quote, they aren't going into rooms. They are running long tubing into the rooms so they can manage the tubing from outside the rooms. So if they aren't going into the rooms, they aren't assessing their patients. So I've said it before and I'll say it again. This really goes to show she has absolutely no knowledge of critical care or even bedside nursing in general. I mean, even what she's saying doesn't make any sense. You don't manage tubing, you manage an IV pump. So running extension tubing so that the pumps can stay outside the door is brilliant. If you have ever worked in an ICU before, you know that the drips and medications that your patient's on need to be changed. They need to go up, they need to go down based on the patient's clinical status multiple times an hour, sometimes even every 5 minutes. So what she expects us to do is to don and doff PPE every 5 minutes to go in and press a few buttons on a pump. That makes absolutely no sense, and it is an incredible waste of resources and PPE and time. So having the tubing stretch so that the pump can reach outside the room actually allows us to take better care of our patients, because if the patient's blood pressure suddenly drops, we can adjust their blood pressure medication. Or if it seems like they might be having some pain, we can go ahead and adjust their pain medication. So we are taking better care of our patients by having the pumps outside the room, because we can easily adjust those medications for the patients. Now, saying that we aren't going into the rooms and assessing our patients, that's just not true. We are going in the rooms, but believe me, we have to cluster our care. We can't be in there for 12 hours straight, so they are going to be alone sometimes. That's just the way it has to be. We can't expose ourselves to the virus for 12 hours straight. That would just be incredibly irresponsible. So the next quote, it's a horror movie, not because of the disease, but because of the way it's being handled. I don't know how else to respond to this. No, it's the disease. The disease is causing the horror movie. I have nothing else to say about that. Okay, so the next quote, they're having people do things that they can't do, maybe things they aren't proficient in. So maybe a nurse who's not familiar or comfortable with using a ventilator, and it's that figure it out mentality. So I would like to have her let me know what exactly hospitals should do in these situations. Hospitals in New York City are running at 100% maximum capacity at all times. Now COVID comes into play and their average census is being doubled, tripled, even quadrupled. So who does she want to take care of these patients? Yes, travel nurses and nurses were redeployed from the country, but that wasn't happening right away. That takes 2 or 3 weeks before we are getting those people into these hospitals in New York City to take care of these patients. So who does she want to take care of them? Like, honestly, you can't just pull a critical care nurse out of thin air. It takes anywhere from 2 to 6 months to train a critical care nurse. So yes, we had to redeploy people from other areas of the hospital that weren't being utilized to critical care, but we don't just throw them in and say, figure it out. That's not how it works. They are being either teamed up with a critical care nurse to be their backup person, or they are being given the most stable assignment on the unit, and they have resources, other nurses, doctors, respiratory therapists who work in critical care there to back them up. But patients need to be taken care of. There are not enough nurses to take care of them. So yes, nurses were being redeployed from the emergency room, from the cardiac lab, from the OR, from the recovery room to help the ICU nurses take care of these patients. It's just something that had to be done until we could get those other nurses redeployed from other areas in the country to come in and help us. So the next quote, buck the system, go against the grain, request records immediately. If there is a medication you want your loved one to be given, report it as a home medication and demand that it be given. This again just goes to show she has no knowledge about how things are actually run in a hospital. Just because a patient reports a medication that they take at home does not mean that it is safe for them to take it when they come into the hospital. If someone comes in with a life-threatening GI bleed and they take aspirin at home, we're not going to go ahead and just give them their aspirin because they take it at home. So if someone comes in and says they take remdesivir at home, that doesn't mean that we're going to go ahead and just give them remdesivir because they say that's what they take at home. That's not how it works. It doesn't make sense. Doctors have to use critical thinking when they're prescribing medications for their patients. They don't just blindly order things because the patients tell them to. So this last quote is the one that absolutely terrifies me, and she says, do not give consent for intubation if you don't want to be intubated or your loved one to be intubated. Demand non-invasive or less invasive ventilation methods. As soon as you give that consent, you might not come out of it. Now, in some cases, it might be appropriate. We just don't know. We just don't know it's being used inappropriately in a lot of cases and that the ventilators are making people worse. So the first sentence, she says, I actually agree with. Do not give consent for intubation if you don't want to be intubated. Absolutely. If you have advanced directives that say you are a do not resuscitate and a do not intubate, you need to make sure that hospital staff know that. We will honor your wishes. You will not be intubated if you have advanced directives that state that. Now, what she is saying is that you are to demand non-invasive ventilation. This might not be safe for you or your loved one. If you have been at home struggling to breathe for days or even weeks and you come into the hospital and your oxygen saturation is 50% and you cannot even speak a sentence, you need to get intubated. There is no question about that. It will save your life. So if you are so terrified because you watched Sarah's video and you are demanding that this person be put on a non-rebreather because you don't want them put on a ventilator, that is just going to make that person in even more distress. So please, you have to know that healthcare providers are intubating people because they absolutely need to be. They're not doing it for any other reason. They don't enjoy intubating people, putting them on ventilators. They are doing it to save lives. All right, so that is going to be it for this video. I don't really know how to end this. This was a very upsetting video to make. I can't even believe that I had to make this video and that someone could be so irresponsible to post what Sarah had posted for the world to see. giving medical advice to people that she has no business giving. Again, she's not on the front lines. She does not see what is happening. She doesn't even have the most up-to-date information about treatment protocols. So please just be very careful with what you are consuming as far as medical advice on the internet. You really want to make sure that you are taking medical advice from a known and trusted source. So I hope this video was helpful. I hope to answer some questions. If you have any, please leave them down in the comments and I'll be sure to get back to you. Thanks again for watching. Bye.